Hello everyone. Today I am here to present my MSK Radiology series. So basically we are all familiar with Crack the Code, right? It's an amazing book, but the only problem that I myself have encountered in that book is there aren't radiological images, the images that we are going to encounter in our daily practice. So I have tried to make an attempt in order to make a slideshow presentation of each and every topic with an image adjacent to it that will help you to better understand and revise all the concepts that are present in the book. So first topic is fracture types. So don't fret, it's not just this little. We'll be elaborating each and every fracture on further slides, right? So we have stress fractures, fatigue fractures, pathologic fractures, open fractures, insufficiency fractures. You don't have to remember them right now. So the first topic is stress fractures. So why do stress fractures occur? It is because either the bone has become too weak or the patient is putting too much stress on the bone. So on the basis of this, there are two types, fatigue fracture and insufficiency fracture. So fatigue fracture occurs when there is abnormal stress on a normal bone, for example, in marathon runners. While insufficiency fractures occur when normal stress is present on abnormal bone. For example, with age, there is osteoporosis and the bones become weak. So while they are climbing stairs, the older generation might get stress fractures. So as we can see here, right? So here is callus formation uh, in the shaft of the second metatarsal, right? So this is an example of a stress fracture. Next, we move on to pathologic fractures. So pathological fractures occur when there is fracture through a lytic bone lesion. Example, metastasis or benign primary lesion either can occur. So here we can see around the metaphysis there is a lytic lesion where while the bone has fractured, right? So a fracture associated with a lytic lesion could be a pathologic fracture. Next, we move on to open fractures. These are also known as compound fractures and they're associated with open wounds. As we can see in these images, right? There is an open wound fracture and they're treated with reduction. So tuft fractures or fingertip fractures are considered a type of open fracture as we can see here. We can see the fracture in the radiograph and we can see open wound. Then we move on to phases of fracture healing. So generally what happens after there is a fracture, there is going to be a hematoma formation under the fracture. After that, this hematoma will have different types of neutrophils, macrophages, and many more cells coming into it, which are further going to form callus as well as blood vessels into it. This callus is further going to calcify, forming a bony callus, and further at the end, we'll have bone remodeling. Right, as we can see in this radiograph, there is a fracture. With time, the fracture is forming a callus. The callus has become bony and the bone has remodeled. So around 7 to 14 days, the granulation tissue forms between the bone fragments, resulting in increased lucency. Hence, many radiologists say that you have to repeat an X-ray after a week or so that the fracture line that was not previously visible might become visible. So the fracture healing time of a few bones are written here. Phalanges generally heal very quickly, around 3 weeks. Tibia is a slow healing bone, so it takes around 10 weeks, while in general, on an average, we can generalize around 6 to 8 weeks for all the bones. So what are the types of abnormal healing? They could be delayed union, could be non-union or malunion. So delayed union is we had an expectation that the bone would heal in 6 to 8 weeks, but it didn't heal during that expected period. So around double the expected time. Non-union is fracture will not heal without intervention. Okay, around 6 to 9 months. Even after 9 months, if the fracture has not healed, there won't be any healing. There isn't any significant callus formation. So example, scaphoid, anterior tibia, and lateral femoral neck. So you don't have to remember these bones right now. We'll come across all of this later. Then malunion is poor anatomic location union. For example, we have a clavicle fracture and the clavicle bone joins together at an abnormal angle, right? That is why it's written crooked. Now, risk factors for abnormal healing, delayed and non-union. not very important, but still vitamin D deficiency because the bones won't be adequately mineralized. Gastric bypass surgery, again, it is going to decrease calcium absorption, and because of that, there will be increased PTH, which is going to cause bone resorption. Then certain drugs like tobacco, NSAIDs, and prednisone steroids. Steroids also cause osteoporosis, right? Then we have a classification of compressive versus tensile side fracture. So in every bone, we tend to put pressure on one side more than the other. For example, either we are putting pressure on the anterior side of the bone, then the posterior side of the bone will start to move apart, as we can see here, right? While we are walking, we are putting tension on the anterior aspect of tibia, while we are compressing the posterior aspect of tibia, while the anterior aspect of tibia is trying to pull apart. So compressive fractures are pushed together, right? When we are walking, the posterior part will be compressed, and whatever fracture line is there, it is going to be pushed together, and it is going to heal. While the part that is a tensile part, it is going to be pulled apart, and because it is being pulled apart, the healing will become very poor. So here we are taking the example of a tibial stress fracture. Most common stress fracture that occurs in athletes. Posterior medial side is compressive, as we saw before, while anterior side is tensile and does not heal well. So considered as dreaded black lines. Right. So here we have an anterior fracture. Now we go to femoral stress fracture. So femoral stress fractures, again we can see we have two areas. One is the tensile part, the lateral part, and the medial part is the compressive part. So the same philosophy applies, either neck fracture or shaft fracture. Then we have something known as spontaneous osteonecrosis of knee or SONC. So it is not a true osteonecrosis, right? It is a type of insufficiency fracture. In elderly people, when they suddenly stand from sitting position, there is going to be injury to the medial part. So sudden history of sudden rising from seated position, or it could also occur after meniscal surgery associated with meniscal injury. So medial condyle is involved, unilateral, and generally no prior history of trauma is present. For example, in this case, you can see there is a medial meniscal injury and there is increased single intensity on this MR or around the medial condyle of the femur, right? Indicating a stress fracture. Now we have calcaneal stress fracture. So calcaneal stress fractures are, so calcaneum is the most fractured tarsal bone, and usually intra-articular fractures are present in calcaneum. Fracture line is generally perpendicular to the trabecular lines. So this is just for your understanding. There are certain trabecular lines. So the fracture line generally occurs like this or this, bisecting this. The lines denoted by these, they are generally bisected like this perpendicularly. Okay, there is something known as a neutral triangle in between. So then we have navicular stress fractures. So again, we can see increased signal intensity over the navicular bone. Generally occurs in runners on hard surfaces and has a high risk of AVM. Further, we move on to March fracture. Again, this is a metatarsal stress fracture involving the second metatarsus and generally occurs in midgetary recruits. Okay. High risk versus low risk stress fractures. Again, as we understood, the tensile side and compressive side. The tensile side will be a high risk and low risk will be the compressive side. Other fractures you can remember from the table if you want. Then we have lateral wrist. Right. So what is true lateral? So true lateral is palmar cortex of the pisiform will be located centrally between the palmar cortex of the scaphoid and the capitate. Right. So here we can see this is the pisiform bone. Right. Right. So if we draw a line from scaphoid like this, and we draw a line across the hamate and the capitate, sorry, the capitate is here, right? So across the capitate, and the scaphoid, and we take the midpoint. The palmar surface of the pisiform will be approximately in the middle of this and this, right? So this is our true lateral view. Next topic will be scaphoid fracture. So it is a very commonly asked topic. Most common carpal bone fracture is scaphoid fracture, generally seen in adolescents and young adults. So as we all know, there is a retrograde flow to the proximal part of the scaphoid. So when there is a fracture, it is more susceptible to AVN and non-union. If you can recall, we just saw that scaphoid is prone to non-union. Most common site of fracture is waist of scaphoid, and displacement more than 1 centimeter requires a fixation screw. So first, now we see transscaphoid perilunate dislocation. So as you can understand from this is, transscaphoid means there is a scaphoid fracture. Perilunate means the lunate is in position and the bones around it have dislocated. So perilunate dislocation has a higher association with the scaphoid fracture, right? So here, as we can see, the scaphoid bone has fractured, and here we can see the lunate is in position while the rest of the hand has dislocated. So it is a perilunate dislocation. Now we move on to scapholunate ligament disruption. As you can see, there is a very famous sign known as Terry Thomas sign. So what happens is, this is the scaphoid and this is the lunate and this is the scapholunate ligament, right? There is supposed to be a scapholunate ligament. Since we cannot see the ligaments on radiographs, we can assume that they are torn when the bones move apart from each other, which are supposed to be together due to the ligament. So here we can see there is an increased space, approximately 3 mm gap is supposed to be present before we say there is an injury. So there are different parts of scapholunate ligament, the volar part, the dorsal part, and the middle part. As we can see there, it is just basically a sandwich. The upper part, lower part, and middle part, right? So the dorsal part is the most important for the stability. So disruption more than 3 mm gap. It is associated with an entity known as DISI that we are going to read further. So seen in 10 to 30% of distal radius and of carpal fractures, this is the Terry Thomas sign predisposed to distal deformity. Right. Then there is something known as humpback deformity. So as there is a fracture at the base of the scaphoid, we have two fragments, right? So when one fragment is sitting on the waist, right, is sitting on the lower fragment. The upper fragment is sitting on the lower fragment, which forms a humpback. So results from angulation of the proximal and distal fragments in the setting of a waist fracture can progress to progressive collapse and non-union and associated with disease. Now here we can see the scaphoid is gone. It is hypointic, right? So proximal pole is at greater risk as we saw before for sinus sclerosis. Adjacent bones will demineralize, but avascular bone will not. Later the bone will become fragmented. MRI will be T1 dark, as you can see here. Then there is something known as Priester disease. So this disease is nothing but atraumatic AVN of scaphoid. So basically you're going to get this picture, but you won't get a history of trauma. Then it will be Priester disease. Then there is something known as slack wrist. Slack wrist stands for scaphoid lunate advanced collapse, right? So there is an injury to scapholunate ligament. Cause could be either trauma or degeneration like CPBD. So here on APV we are seeing first is styloscaphoid osteoarthritis, right? Number one, as we can see here, this is the styloid process, this is the scaphoid, and there is increased density. So we are interpreting osteoarthritis. Then second is radioscaphoid osteoarthritis, which is most commonly involved. And third is capitolunate osteoarthritis, right? So this is the capitate, this is the lunate, and capitolunate osteoarthritis. On the lateral view, we can see there is dorsal tilting of the lunate. This is the volar side, this is the dorsal side. Lunate, instead of being like this, has dorsally tilted, and there is a deciduoformity that we are going to read later. So this is slack wrist. Then there is something known as snap wrist, scaphoid non-union advanced collapse. So this wrist is associated with a scaphoid fracture. right? So on frontal view, we are seeing here again the same thing, radial and steroid osteoarthritis. The black arrow here is pointing to narrowing of lunocapitate space. So basically what happens in this is the capitate, the support of the capitate below it is lost and the capitate falls down and hits the lunate. After it hits the lunate is going to be displaced towards the ulnar side or medial side. Right, so there is ulnar translation of lunate, there is narrowing of lunocapitate space due to proximal migration of the capitate. On the lateral view, there will be dorsal tilt of lunate with increase of scaphoid lunate ligament angle. Right, so scaphoid lunate angle has been denoted. So this is the lunate. So this is the angle. This is the straight line perpendicular to the lunate, and there is a line along the long axis of the scaphoid. So now we are finally on the topic at hand, known as DISI, dorsal intercalated ligament instability. Dorsal intercalated ligament instability. There is dorsiflexion instability, as we are mentioning, dorsal, due to scapholunate ligament injury. So post right-sided injury, right? So since scaphoid is a radially sided bone, so once there is a radial injury, there will, that is the scapholunate side. Lunate rotates dorsally. Lunate goes dorsally. Again, everything is dorsal here, and there is increased scapholunate angle by known as 60 degrees. So normal is like this. When lunate rotates, there is going to be increased angle, more than 80 degrees. Generally, some books mention 60, some books mention 80. So this was the volar side, this was the dorsal side. It rotated dorsally, so the angle has increased, right? So there is another entity known as VISI, volar intercalated segmental instability. This is volar flexion instability, right? Volar flexion instability, which happens post ulnar sided injury, right? Opposite of DISI. So here lunotriquetral ligament. Till now we have had scapholunate ligament injury. Now we have lunotriquetral ligament injury, and it is relatively rare. And scapholunate angle decreases from 60 degrees, right? It becomes less than 30 degrees in VC. Basically, the bone has rotated on this side. Now we have carpal dislocation. Different types of carpal dislocation are seen here. First, we see the normal, all are aligned. Then we have perilunate, as we saw before. Then we have midcarpal, both the upper part and the lunate have dislocated. On the other hand, then we have lunate dislocation, which is most severe. This is according to severity. Normal, perilunate, midcarpal, lunate. Then we have something known as vulnerable zones theory. So arcs of vulnerability, if you know, there are different arcs. Number one is seen around is a purely ligamentous injury, as you can see here, right along the lunate. As you can see, there are ligaments here. That is a purely ligamentous injury. Then R2 is a greater arc that involves the bones, as you can see. So bony points of failure associated with fractures, trans name of fracture, dislocation. Example, scapholunate dislocation occurs due to this. Then R3 is involving only trapezium. Okay, then there is something known as space of Poirier. It is a ligament-free area, right? As you can see, there are ligaments here known as short radial lunate, there is ulnar lunate, there is ulnar triquetral, there is long radial lunate. So around lunate, there are so many. That's why the first arc was there. Then there is a ligament-free area between radioscaphoid capitate and long radial lunate known as space of Poirier. So it is a site of weakness. There are synovial spaces in the wrist. Okay, so we know there is something known as pisiform recess and the wrist joint known as radiocarpal joint, which are normally communicating. So we undergo arthrograms to see these spaces. So here we can see in wrist arthrography, here we can see the pisiform recess, the pisotriquetral joint as well as the rest of the wrist. The triangular fibrocartilage complex that we'll see in further lectures is intact. So this is TFCC. This will cover from the next lecture. Thank you for watching. Hope we meet again. Please subscribe and comment in case you want something more. Thank you.